Our second lecture in the series of lacrimal drainage system would be initial evaluation. So we will obviously start with the history. So inquiry should be made about ocular discomfort and redness to aid in excluding hypersecretion. Drainage failure tends to be exacerbated by a cold and windy environment and to be least evident in a warm, dry room. A complaint of the tears overflowing on the cheek is likely to indicate drainage failure rather than hypersecretion. Coming to the external examination, punctal abnormality is the most common cause of lacrimal drainage failure, so the puncta and eyelid should be examined using a slit lamp. It is critical that examination of the puncta is performed prior to cannulation for diagnostic irrigation, which temporarily dilates the punctal opening and masks stenosis. There will often be obvious tear flowing from the medial or less commonly the lateral canthal region. Visible mucopurulent discharge is more likely to occur with nasal lacrimal duct obstruction than a blockage more proximally. Now, punctal stenosis, as shown in the figure here, is extremely common and has been reported as present in up to about half of the general population. Over half of the patients with evident stenosis are asymptomatic, in many cases due to insufficiency of tear production or increased evaporation. The picture here shows this punctal stenosis. It looks like the inferior puncta. So we should look out for this in patients presenting with epiphora, and this should be one of the things that should be looked at. Now, ectropion either localized to the punctal region or involving the wider lid is often associated with secondary stenosis, as seen in the first picture. As you can see, there is a mild medial ectropion here in this region, and the punctum is also everted, resulting in watering. Then comes the punctal obstruction, usually partial by a fold of redundant conjunctiva, also called conjunctivochalasis, which we will discuss in detail. It's a common pathology, but it is very underdiagnosed. Occasionally, an eyelash may lodge in the ampullae, as seen in the figure here. The arrow pointing towards the eyelash, which is lodged in it. It can be seen very clearly on slit lamp examination, and removal may result in relief. A large caruncle may displace the punctum away from the globe, as is shown here. It's a large caruncle, and we can see that the punctum area is displaced. Then, in the presence of substantial lid laxity, the puncta may rarely override each other, and which can also result in watering. Now, a pouting punctum, as seen here in this figure, is typical of canaliculatus, which we will discuss in detail later on in another lecture. The eyelid skin will often be moderately scaly and erythematous in chronic epiphora. Centurion syndrome is characterized by anterior malposition of the medial part of the lid, with displacement of the puncta out of the lacus lacrimalis due to prominent nasal bridge. This is something that should be kept in mind. Might be an important question for exam. So we are going to keep Centurion syndrome in mind for examination. Now, in a small child, the commonest cause is punctal stenosis. Occasionally, congenital glaucoma can present in this fashion. So, congenital glaucoma patient, a child will present with watery eye. Now, coming towards the next system, which is the lacrimal sac. It should be palpated Punctal reflux of mucopurulent material on compression is indicative of a mucocele, that is a dilated mucus-filled sac with a patent canalicular system, but with an obstruction either at or distal to the lower end of the lacrimal sac. In acute decrocystitis, palpation is painful and should be avoided. Rarely, palpation of the sac will reveal a stone or a tumor. All of these pathologies I will discuss in the upcoming lectures in details. So this is the initial examination. Our next lecture will be detailed clinical and lab investigations. So that's it for now. If you like the lecture, please click on the like button and subscribe to the channel. Thank you.